Hello. Hello. Is anybody there?
Hello, hello.
Hey, Eric. How are you?
Hello, Joe. Eric, how are you?
Hey, how are you?
Hey, Joe.
I'm good.
So either it's going to be very crowded today because we had a lot of snow overnight in the East Coast, or everybody's still sleeping.
Everybody's at home. They can come online from home.
Yeah, it's exactly right. It makes it easier. So, hey, Dan,
Yes.
um, uh, are are we going to do anything at the ACC?
Yes. I was just thinking about that this morning, and we are. There have been a lot of moving parts in the last week or two, so trying to just get our pieces all together, and then do something
So,
at ACC.
so there's kind of an interesting thing going on with the ACC. I got a call. I guess I got an email like last Thursday um, that out of the heart failure group, they want to develop a subgroup of about cardio-oncology, or at least a task force.
Awesome.
So Pam Douglas, I think, is heading it. And,
Great. Well,
uh,
that's uh, that's fantastic.
and I and they want to have a conference call before and then a meeting sometime at the ACC. I
Well, that would be really fantastic if we want to try to. I mean, as as we as we discussed through email, um the whole idea about the fellowship and sort of organizing our thoughts on the fellowship is that being one of the main components of our meeting at the ACC, then those two things might dovetail quite nicely.
So it's actually interesting, right, that Lavinia has interviewed all over the place. So she's been to WashU, to Cincinnati, Wisconsin, Colorado, in New York, um, across the river here, and the overriding concept of the cardiology people that she's meeting is uh, this is not cardio-oncology isn't something that's viable, and we can't just hire somebody to do cardio-oncology.
That it's
Kind of
not viable.
not. I think
Not. Yeah.
maybe St. Louis is a little different because of Ron's influence, but well, at least what she's been telling me, people, the feedback that she gets is, well, our oncologists aren't interested, or there's not enough, and um, we're not. It's not on our radar. It's like at the bottom of our radar screen. Very interesting.
That is. I'm a little surprised by that because
And now
that had
somebody where she was at Wake Forest. So the guy at Wake Forest came from Vanderbilt, right?
Dave Zhao. Yeah.
Yeah. So he said he understands it, but it's not like his priority.
Yeah. Well, that I can understand that, knowing Dave.
Yeah, I don't know. So anyhow, this is like everything else. It sputters. It takes, you get a couple steps ahead and one back till this really takes off.
Well, and I think that having Pam Douglas uh, involved in making suggestions from basically from inside ACC, I think is quite important.
Yeah. So I'm going to. I'm actually looking for. Who is anybody else on besides us?
I don't know.
So a lot of people might think it's
Let's see.
9:30.
No, we've only got the three of us right now.
So it may be that people think it's 9:30 because of what we've been doing otherwise.
Yes.
Um, so I'm just uh, see if I can find. So So as long as it's only the three of us, um, I just I apologize for the moderator of your session. I couldn't get him to change it.
Oh, yeah.
I go,
Don't
I
worry.
can't believe that this is happening.
Don't worry about it. That's fine.
Yeah, but I need to know it wasn't me, and
Sure. I know you did it. I
I
mean,
copied.
don't try to weasel out of that. I knew you did that. Come on.
No, I really weaseled it. I lobbied those guys to forget having um, uh, as a moderator, but as an actual participant. So anyhow, let me tell you who, because they sent a doodle thing to try to pick a date for the webinar. So Anna Barrick, Pam Douglas, Cesar Alescu, Stephanie Mitchell, who I don't know, Gillian Murtaugh, who you know, Tochi Okwasa, who I don't know, Tom Ryan, who, if it's the old Tom Ryan, who's alcohol cardiomyopathy guy, is a heart failure person, and Matthew Wannett. So should I tell them to add you to the thing? Are you interested?
Sure.
Sure.
But about half of those people I didn't know. But
Yeah, I mean, I think that because it came out of like the heart failure guys.
yeah, well, so that's kind of been an interesting dynamic lately. I don't know if you've caught wind of this, but there's the Heart Failure Society, which that started more than a decade ago.
Right.
And then now through the ACC, they're basically trying to have essentially like a heart failure society. But, that has the power of the ACC, which is obviously a bigger deal than the Heart Failure Society.
Unfortunately, a lot of what we do, there's politics. And that, I don't know if we ever talked about it, but that, in the old days, I mean, I guess in the 50s, that there was the AHA, and that there were a small group of guys, Bill Wyckoff and Jeremy Swan and people like that broke off from the AHA and started the ACC. But there was no compelling reason for that to happen other than the same thing that you're talking about with heart failure and the same thing that goes on with oncocardiology. It's like absurd.
Yeah, well, I mean, you can't really, I don't know how you officially deal with that. I think you just sort of keep going in the direction you're going, and
I have my own agenda, and I don't want to have it. I try not to make enemies. They're stupid.
That's right.
But we would be much better off if we were all on the same page.
Yes, well, we're trying to do that, and since it's just us on the line, Eric has been doing a lot of homework in the last week or two, so we're trying to, develop a ICOS North America and have a
That's good.
501c3 and, have an entity that we can solicit some support for and then use that to sort of enhance the educational and research message.
Yeah, so I think that makes sense. Do you have any fellows at Vanderbilt that want to do a cardio onc here next year? Do I have a spot?
Yeah, I mean, we have, I would say 2 would be our ordinal number. You probably would say it's more like 1.25 that we have two fellows that have been significantly involved in cardio-oncology.
If somebody wants to do a year, I have funding and I have a spot in, and I've only gotten one response to our ad, and going out and trying to find somebody.
Okay, well, that's great. So Eric, do you want to explain what you got this on the screen there, the perfect algorithm?
We have Eileen Diamonds here, so we want to welcome Eileen.
Hello.
Hello.
Hey, Eileen, how are you? And,
Can you hear me?
Yeah, I can hear
Yes.
you fine. Thank you.
Okay, thank you.
Actually, I was waiting for you, Dan, to put your slides up, so I just stuck this up as a provocative slide to stimulate you to ask about it.
Okay. So I know. I mean, it's,
This is a bait and hook. And,
All right. Well, I'll take the bait.
I think you're nibbling. I think you're nibbling on this, and so this is what I've been doing in my practice now, and it's I call it the perfect algorithm. And you see at the top, this is we got the MI-RISC VP test, which is an international test, but it's not available in the United States right now. And these are 7 protein markers that have to do with coronary artery disease, but not necessarily plaque burden. And then the Chorus CAD is CardioDX's product, which is 23 messenger DNAs, 23 messenger DNA or RNAs, messenger RNAs that basically are correlated with plaque burden, which has a correlation with severity of atherosclerosis. And so I'm using both these tests as screening tests, and if you're negative here, you're pretty good, and if you're negative here, you're pretty good, but if you're positive, I'm interested in doing a cardiac CT. If you're positive on either one of these tests, and if you come out to have a greater than 50% blockage by cardiac CT, and then we're going to do the heart flow analysis, which is beta testing right now, which that's Charles Taylor from Stanford, and that's 9 months away from FDA approval, and that'll give you FFR across these lesions. And of course, if FFR is less than 80, and if we have substantial symptoms and medical management and patient is still not satisfied, possible bioabsorbable vascular scaffold, which I think is our best stent right now, from what I see from Dr. Colombo and Milan and Dr. Patrick Suarez in Rotterdam. And then if you're less than 50% obstruction, we're looking for the plaque that has the lipid core, which the red signifies the low Hounsfield units, and the blue is fibrous tissue, which is higher Hounsfield units, and then the channel is the green, the main channel or the lumen. And then if you've got a thick fibrous cap, this is signified by greater than 150 Hounsfield units, which is this little yellow one on top of this one. But you can see this one does not have a thick fibrous cap. Actually, it's a thin fibrous cap, and it's less than 150 Hounsfield units, but greater than 80. And so that's a risky lesion. So not only is there a stenosis, but also there's a thin fibrous cap. And so we're looking at this plaque that actually ruptured 12 days later and caused the STEMI. This is in the LAD. And so this was a high-risk plaque that I recognized at the time, and a gentleman who was asymptomatic and recommended that he start on some medications, and I gave him some prescriptions. And also we were going to do stenting after the holidays on an asymptomatic guy because he had a high-risk plaque. And he was playing a video game and didn't get his medicines filled. Actually, he got them filled and didn't start them. He was going to start them on Monday. And Sunday he was playing a video game and ruptured this plaque and had a STEMI, and we had to stent him. So this was picked up 12 days before the event. And so this is sort of what I call, and then there's a positive nod, which we see all the time with CT scans. We now have a genetic marker to follow. Instead of following CT scans, we can follow the Expresses lung test for the genetic marker, which has a very high sensitivity for a lesion that is basically malignant. And so this is sort of a little schema that I'm calling the perfect algorithm that I just wanted to present to you out of interest today, and let you ponder for a while, and we'll talk again. But I'm going to give you as the presenter. I'm going to change presenters to you so you can get your slides up. And you have been changed to presenter, and you are okay. And then we have Susan Dent, who's up today, and it looks like
Hi.
she can speak. You can speak today, Susan.
I can. Can you hear me?
Oh my goodness! I
I know. Isn't it amazing? We finally figured it out.
I can hear your beautiful voice, and I can hear your Canadian outs.
Well, we're freezing.
Joe Carver, good morning.
Hi.
We've got the core group right now, and I think others are coming in at 9:30 probably because of the way we've been scheduling stuff at 9:30. People get used to it.
Yeah.
Well, we'll go ahead and get started because as we go through the details of this case, it might lead to a little longer discussion than 30 minutes. So anyway, this is a interesting case that we've had just in the last couple of weeks. So she is a 77-year-old who had a past history of non-Hodgkin's lymphoma that are presented as a sacral mass that was treated with chemotherapy and radiation in 2006. And then in December of 2013, she noted a small right breast mass. She underwent evaluation for that. The biopsy was positive, and she had a partial mastectomy. And at the time of that, there was one lymph node that was positive. The pathology was triple negative, ER, PR, and HER2 negative. And then after that surgery, they were preparing for whatever the subsequent treatment may be, and she developed significant palpitations and near syncope in the clinic visit when they were going to discuss the treatment plan for her breast cancer. And her heart rate was noted to be 35 in clinic, and she was admitted to the hospital. In addition, she reported PND and orthopnea over the past few weeks that had been progressive and impairing her ability to sleep. So her past medical history is largely noted for her lymphoma. In 2006, sacral mass, she got 6 cycles of CHOP and Rituxan, and then had local radiation in her sacrum. Some point after that, it wasn't entirely clear, but the first indication of it showed up in 2008, that she developed left ventricular dysfunction and heart failure, and EF was estimated about 30 to 35% at that point. She was, as far as I could tell, because this was all occurring at a different hospital, but she was only on an ACE inhibitor, and her functional status was pretty limited, but there had been no major issues until 2012 when she was admitted here at Vanderbilt for heart failure symptoms. And at that time, she had a cath that showed normal coronaries. And as mentioned, so in 2012, she had only been on an ACE really for about a year, but had never been tried on a beta blocker. So when she presented after her clinic visit, in which her heart rate was recorded at 35, she presented to the hospital. Blood pressure was 93/60, heart rate was 76. She was afebrile. Respirations were about 20. She had significant JVD, had some crackles. Cardiac exam, she had a regular rate and rhythm, but a soft holosystolic murmur, a soft S3, and her PMI was enlarged. Her abdomen was fairly unremarkable. Extremities showed edema to at least her mid-shins, and she had good pulses. Her basic labs are indicated there. Her sodium was 132, potassium was normal, BUN and creatinine were okay, hemoglobin was 10.1, platelet count was okay, LDL was only slightly elevated. Her BNP was markedly elevated at 2,700, and her troponin I was barely abnormal at 0.07. So here's her EKGs on presentation. So Joe, since you're snowed in, can you interpret these EKGs? Top one is the current one, and the bottom one is about 6 months prior.
Yeah, so it's sinus rhythm with at least some minimal voltage stuff for LVH and some the PR interval. I don't have calipers, but eyeballing it looks like it's top normal, and just some non-specific T-wave flattening all over the place. It has an LVH look, but doesn't meet all the criteria.
Yeah, and then do you think there's any significant difference?
So there, I'm just looking at the first one. I mean, I think that there's a nubbin of an R wave in 3 and AVF. So the second one, it still looks like sinus rhythm. The pure interval looks like, again, eyeballing, it looks like it's pretty much the same. They're now, the T waves are now more upright in the inferior, actually everywhere. So there's this, oh, you know what, I got them backwards. So 6 months prior, I looked at the top one first. So in the first one, just reverse what I said. So there's new T wave flattening diffusely. The voltage looks pretty much the same. Non-specific stuff.
Yeah, and so all the other things that you mentioned were present previously.
Yeah, the T waves were upright in 2, 3, and F, and in V4 through V6, and now they're either biphasic or flattened.
Yeah, and then the only other finding that may not project very well, but her QT interval was probably a little bit prolonged on the current EKG compared to the previous. So if you look, say for instance, at AVL,
like eyeballing it like 400.
Yeah, it was
maybe a little
higher than that, but
20.
Comparing the two EKGs, there was probably a significant difference, but it wasn't obvious, or I mean, it wasn't really blatant. It was just.
So when you were telling the story, I thought for sure you were going to show us a left bundle branch block.
Yeah, you would think that would have been something that you might anticipate in this patient for sure. So here's her chest X-ray. I don't know if somebody else wants to.
We have Dr. Morales, our cardiac fellow here, so we would like the fellows to be called on.
Yeah.
Sure. All right. So this definitely looks like cardiomegaly. There's a little bit of congestion in there. Heart borders are definitely enlarged. Can't see the left border, but there's probably a little pleural effusion just on the left side over there. Pretty consistent. Looks like CHF. And there's also, no, that's not a line. That's just an EKG lead.
Yeah. So since I might be the oldest person on the call and had to take care of patients before we had real echoes, that this is a classic left atrial enlargement. Look at the way the bronchus is
splayed.
Yeah.
Yeah, and actually you get a suggestion that the pulmonary artery is enlarged, just based, at least on the right side there. So, and then she has a port they had placed that in anticipation of possible chemotherapy. Okay. So while she was admitted, she had multiple runs of AV nodal reentry tachycardia that was noted on telemetry. They were short. We never got a 12 lead to capture it, but you could see it on the telemetry strip. It seemed pretty obvious that that's what it was. And then she also had several 7 to 10 beat runs of VT that were noted, and they were distinctly different than the AV nodal reentry tachycardia. During her 2 or 3 days in the hospital, she had no recurrent syncope, and then she had a PET CT scan that showed a right axillary mass that was a little more than 2 centimeters. And she also had an MRI that showed an EF of 27%, an RVEF of 32%, and no gadolinium enhancement. So, Gene, I see you're on. Do you have any comment about those developments in this patient?
Actually, I came in so late that I don't have the clinical context as missed the initial presentation.
Okay, well, she had lymphoma in 2006 and was treated with CHOP-R for 6 cycles, and then had an apparent heart failure episode in 2008. Did okay on minimal therapy for a number of years. In 2012, got admitted for heart failure, had a cath, showed normal coronaries, and then in 2013 had noted a right breast mass, had a partial mastectomy, and 1 positive lymph node, and then was being seen to evaluate for what the next treatment of her breast cancer would be, and she developed some syncopal type symptoms, had a low heart rate recorded in the clinic, and was admitted.
A low heart rate, you said, in clinic?
Yeah, it was recorded at 35.
Oh.
But not an EKG, just a physical exam.
Oh, I see. Okay. Huh. And now she has this low EF.
Yes.
And so all the other things have been excluded, like, thyroid. How old is this person?
77.
So I, would wonder if this was related to her RCHOP therapy previously. And then I guess the question with her EF being that low, assuming that she'd done reasonable medical therapy, would be with syncope, what you would do about it. She has VT, so you would wonder about the role of defibrillator in her. So her prognosis from breast cancer perspective is relevant.
Right, and so I'm not sure we know the answer to that yet, although the PET CT scan and the right axillary mass was read as very suspicious for a metastatic lesion.
Okay.
So,
Hey, Dan,
sorry,
can you go back to the chest X-ray?
Yeah.
Yeah, okay, we didn't miss it. Go ahead.
so can I just make a comment about the breast case?
Yes, we would appreciate that.
Did she have, initially, did she have a sentinel lymph node biopsy?
When she had her partial mastectomy, they did do the lymph node sampling, and 1 was positive.
Because it's unusual to have a 2.7 centimeter right axillary mass. I'm surprised they didn't pick that up. But anyways, the important thing beyond that would be other staging investigations. So did they do bone scan, CT, chest, abdomen, looking for any evidence of other metastatic disease?
I don't know about the bone scan, but the CT, yes, and basically the PET scan is a summary finding from what they found.
So from a breast cancer perspective, she's triple negative, and that's bad. It means you have no options with regards to endocrine therapy. And if you look at the biology of triple negative disease, it's by far the most aggressive in terms of risk of relapse. So this would be bad. We wouldn't have, in terms of systemic therapy options, other than chemo, there really is nothing else we can do to reduce her risk of recurrence. Now, if this is a mass, just one mass in the axilla, it might be worth, depending on how she does cardiac-wise, them going after that. But it's if she didn't have a full axillary lymph node dissection, I'm sure that's one thing that would be also on the table to discuss.
Yeah, and I think that at some point there was some discussion about radiation therapy. I don't know if you feel that.
It's a large mass, though, right? I mean, I guess if she's got so much else going on that they didn't want to go back in, but that's a large mass for radiation alone. Anyways, her systemic risk, that would be local management. So there's two issues of local management, but her risk of systemic recurrence is very high.
So, and then as Jean mentioned, so we got some rhythm issues here, and we have LV dysfunction. And as a side note, this patient had not been treated optimally by any stretch at this point for heart failure. What would you say about her prognosis for breast cancer? I mean, you mentioned the triple negative part is tough, and then
right.
You got this axillary mass, and that's certainly not a benefit. And then the question is what would you say her overall survival is?
So the fact that she has the mass, I mean, if it is a lymph node mass, that still would mean she's stage 2, right? So she's not, from a breast cancer perspective, she would still be, if you could deal with that mass, sort of potentially curative, irrespective of the fact she has really bad heart disease. What we do sometimes, given, I would say, node positive disease, triple negative, her risk, now usually what we look at is the risk of recurrence over the next 10 years. One way we look at it sometimes is a program called Adjuvant Online, but her risk, would be somewhat counteracted by her comorbidities. So I'm probably saying in the 40 to 45% risk group. Having said that, it's going to, when you look at risk, you have to take into consideration her cardiac risk as well, right? So one will play off the other, but it's fairly high. And the thing about triple negative is that it's the first 2 years. So they tend to be at the highest risk for the first 2 years at a particularly higher risk. And then after that, that risk comes down over a number of years so that at about 5 to 7 years, their risk is the same as a woman with ER positive disease. So it's a high peak at the beginning.
Does it matter to you, or do you think it has any impact on the fact that she had lymphoma originally, and that was treated with chemo, and does that have any?
Absolutely. So did she have mantle or radiotherapy? I imagine. Did she have any?
She had it to her sacrum. Her tumor was in her.
Oh, that's
sacrum.
right. That's right. So she was. So no, it wouldn't be a. So the only time that we see increased risk is when they've had the chest radiation, and then you see breast cancer 20 years down the road. So I don't think that. So the only issue for her, in my eyes, I mean, you need to deal with her cardiac issue is, no anthracyclines, but there are other therapies that can be used for triple negative that would avoid using an anthracycline. There is some data out there looking actually at CMF. So I mean, CMF has been around for a long time. That would be a possibility. The other possibility would be using a taxane-based treatment, something like TC, which is 4 cycles. So we at our institution have had a few cases of women with triple negative who could not receive an anthracycline, and those are the two possibilities we've looked at, CMF and TC.
Okay, that's a really great discussion. Just to sort of round out the rest of her cardiac picture, these were her medicines after she got admitted. As I mentioned, she had only been on Altace over the last couple of years when she had known heart failure. And the spironolactone, Lasix, Coreg were all started on admission. Synthroid was a standing medicine for her. Can you guys see this?
Yes.
Yes.
Do you see it? Do you see the picture moving?
Yes.
Okay. I think the other one will pick up here in a second. But this is her Cath from 2 years prior in 2012. And so we have Ron. I see he joined. Is he speaking? Do we have Ron's voice?
Hello, Ron. We've got you unmuted.
Oh, hi.
All right,
Sorry, I'm
Ron.
late.
No problem. You want to take the Cath on here?
Well, it looks
Tell
pretty
us.
normal from what I'm seeing. It's a cranial, right areocranial view. You see the LED looks real good. The circumflex is going up. We don't see much of it, but what we see looks normal. The LV angio, let's see it beat a minute. There we go. Looks like a lot of PVCs, but I'd have to say probably normal. The apex looks a little funny, but I think it's normal with the PVCs. So I'd say basically normal.
Yeah, so the coronaries were felt to be unremarkable, as mentioned. The LV gram was read as EF about 35%. This was 2 years ago. And of note, there was only minimal mitral regurgitation, which for the cardiology people on the call, then, you know, at least from this Cath, you don't really see much evidence of mitral regurgitation. But her overall EF was felt to be sort of moderately depressed, although it looks pretty good on that view. I agree.
Yeah, I mean, it's all PVCs, and by the time it beats normally, you're going to get a depressed LV sometimes from the contrast, so it's hard to know exactly what it is.
And then here's her echo from 2012, and she had an echo on admission that was done in the emergency department, and it so, you know, would have been from 2014, but it was so technically terrible that I couldn't possibly show it. So
Dr. Morales will be glad to comment on the echo.
Sure.
So I can say that this echo from 2012 is reflective of what her current echo is, but it's better images.
Okay. Well, you know, the EF looks a little bit down. It's kind of hard because of the delay, but it looks globally down. All walls look a little down. Left atrium is enlarged. There's quite a bit of mitral regurgitation. From here, it looks moderate, at least by color. And the left ventricle looks a little dilated.
It was read as severe by the echo people in 2012.
Yeah, I mean, you should never really quantify by just a color flow, but yeah, I mean, it's probably accurate if it was dense and triangular peak and all that. So.
Well, and then the interesting thing is that from this echo with severe MR, according to the echo, the Cath, which was done within about a 2-day period, the Cath showed really no significant MR. So
yeah.
Well, there's a lot of other things to look for severe MR besides just that, you know, that Doppler strand. I mean, you've got to look at like pulmonary vein systolic reversal, or you know, the whatever it is, the thing around the mitral valve itself, and I think you need all that to tell.
Yeah, no, I didn't show all those images. That would take too much time.
Well, of course,
to
I
go
assume they
through all
were.
that.
Yeah,
And you know, the other Doppler parameters suggested that although this was read as severe, suggested that the mitral regurgitation was more in the moderate range when you looked at all the other parameters. Okay. So what do we want to do now? So we have a patient that has LV dysfunction.
Dan, can you hear me?
I can, yes.
Eileen, can you hear me?
I can.
I just have a quick question. Is the axillary node definitely breast cancer versus lymphoma?
That's a really good question. And so no, we don't know that, and I think, you know, Susan sort of mentioned whether we should biopsy that. And
Yeah,
you
it's
know, I
just
don't
one
know
of
that because it didn't look like there was any other active disease in the sacral area. But you know, this was a very hot axillary lymph node, 2.7 centimeters.
Yeah, it's very large, right? Exactly.
So I think that
All right, so Dan,
yes.
yes. No, keep going. I'm sorry. So,
Well,
you know, when you look at the LV-gram from 2 years ago with all those PVCs, so one issue that comes up is whether this is a PVC-related cardiomyopathy. It has a substrate related to anthracycline exposure. I would try to quantitate what her ventricular ectopy burden is at this point, because that may drive you in a different direction.
that's interesting. So actually, the arrhythmia team was consulted, and you know, they acknowledged the AV nodal reentry tachycardia and the VT that we saw on the telemetry. And because of the unknown status of her cancer, they felt that, you know, there was a significant arrhythmia risk here, and that she should go home on a life vest. I don't know.
Here they would have wheeled her into the EP lab in like 20 seconds.
Well, I would normally have said that may be true, but you know, we don't fully understand the degree of her cancer at this point. But and she hasn't even been on any medicines whatsoever, you know, other than an ACE.
Now, I'm not talking about a device. I mean, she might be a really reasonable person to ablate the AV nodal stuff and the VT if there's a VT focus. Her ventricular function might significantly improve, and you could hold off the device decision for a little bit.
Okay, so there's one suggestion that we should pursue the arrhythmia story in more detail with perhaps an EP study and or ablation. Does anybody have any other votes? I guess Eileen also mentioned that, you know, we might want to know a little bit more about this lymph node.
Yeah, it definitely should be biopsied.
And then
I agree.
yeah, well, and then Susan mentioned about possible chemo options in terms of the breast cancer.
Yeah, I think.
Sorry.
Sorry, go ahead.
I would just wonder, you know, should we implant a device at this point, or is this life vest a reasonable suggestion or observation?
I think she should have an ICD placed. I think she's had a low EF since 2008. She's been having these symptoms of near syncope. You know, she's lucky she hadn't had sudden cardiac death at this point. So I think the right thing to do would be to go ahead and put an ICD in her. I think EP studies in non-ischemics is very low yield, and I don't believe her pre-syncope is probably related to AV and RT. I think it's probably more VT, non-sustained stuff. So I think going ahead with an ICD would be the right approach, and then optimize her medically. I probably wouldn't have put her on a beta blocker on admission. I probably would have optimized her volume status first, and then put on a beta blocker, and plus or minus depending on what her burden of ventricular stuff is, maybe some amiodarone or sotalol or something at some point. But if she persists having stuff. And she had a Cath about 2 years ago, very clean. It's unlikely she's having progressive coronary artery disease at this point. So that's kind of how I think she should be managed.
Susan, you wanted to make some other comment?
Well, I just wanted to say that, you know, there are options for her with regards to systemic therapy that completely avoid anthracycline. So, you know, if this mass is related to her breast cancer, certainly they can go after that. And there are sort of non-anthracycline based regimens that would be reasonable to offer her, such as CMF.
Right. So this is how it played out. So we've had some good discussion about options. So the EP service felt that, you know, a device might be appropriate. However, they didn't want to put it in right now because they didn't know, you know, they didn't know the status of her cancer, and so that's why they recommended the Life Vest. But you know, that's a Life Vest, especially in somebody who has a port, who's getting, you know, potentially getting chemo and all of that, is really not a great story. And but this was presented to the patient, and when we looked at the expense to the patient for putting a Life Vest for the next couple of months, she declined that option. So no Life Vest. And then we did diurese her, she lost, you know, 10 or 15 pounds at least, and then put her on, you know, low-dose Coreg, spironolactone, ACE, and a diuretic, as mentioned. And she was doing better, and we weren't having any rhythm issues, any significant rhythm issues for like 2 or 3 days. So it was opted to let her go home and then see her oncologist in the next week to, you know, sort of put all this together. And actually the oncologist recommended exactly what you said, Susan. So they opted for Taxol and Cytoxan as chemotherapy for her breast cancer. And I think there was discussion about biopsying that lymph node, but I don't believe it's been done yet. So I think, as Eileen asked earlier about whether that's lymphoma or not, I think that's a really important question, and I'm not sure we know the answer to that. So, you know, there was some discussion about whether anthracyclines could be given in this setting, and you know, I pretty much said as what Susan said, that I didn't think that would be such a good idea right now. So I don't know, would anybody be willing to do anything more aggressive than CMF or TC, as Susan mentioned? Or
I personally wouldn't, as an oncologist, and you know, there's actually good data on TC and actually data on CMF and triple negative. So I think the nice thing here is to say that there are options. So why rock the boat when you already have reasonable options that there's good data on?
Good. Yeah. No, I mean that seems very logical. And then so it sounds to me like we should probably pursue that hotspot with a biopsy. That sounds like something that's important in terms of decision making. And so,
and the other thing to point out too is that.
So go ahead, Sue.
Sorry. Yeah, I was just going to say is that, you know, these sort of local treatment issues such as the axilla, you can always tackle those after the systemic therapy too, right? So, but I wouldn't. I don't know if their plan is to just give her radiation to that axilla, but it's my only concern if you were just to give radiation. It's a big mass. I mean, that's a big mass to try and get rid of with radiation in a curative sense, right?
Yeah. So then, Dr. Morales, since you were so clear about the recommendation to proceed with the device, so she has a left-sided port, and she has cancer in the right, and there's a consideration of perhaps radiation. Does that factor into where you would put that device?
I think some of our electrophysiologic colleagues may tunnel it and put it lower down in the belly if there's a thought that there would be radiation up in that area.
Are you going to use the low profile one?
Yeah, the
profile defibrillator, the new one.
Oh, you're talking about the external,
The subcutaneous.
the subcutaneous. So that would be an option. However, if she's having episodes of bradycardia, it wouldn't be able to necessarily pace her in the event of bradycardic spell. So that I don't know if that would be a good option for her. But yeah, that would be another option. Would be the external ICDs. I don't know how many.
It's not external, it's low profile.
Yeah, yeah.
Yeah,
But yeah,
I
I think placement issue would be an issue if she is going to have chest radiation.
Well, and I think that there certainly were, selected cases where we had to actually move a device because they had recurrent cancer in the area where the device was placed. So in terms of sort of forward-thinking planning in this person, I would probably say they shouldn't have put the port in the left. I think they should have put the port somewhere else and not have that occupied as the location for where you would put an ICD. Because since her cancer's on the right.
Yeah, so if there's a device, the obvious thing is to move the port to the other side.
And then, Susan, does the port being on the right have any bearing in terms of chemo and radiation and all that, where the disease is?
No, I mean the other option would have been, I'm not sure, I can understand putting in a access, but when we're looking at giving patients only 4 cycles of chemo, which is what TC is, I mean often I just put in a PIC, which you can put in and pull out after 4 cycles. So, but no, from my perspective, they always usually just go to the opposite side, right? They tend to go to the opposite side. So
yeah,
I don't see. And also the other question, the reason why they go to the opposite side, of course, is if they're radiating, right?
Yeah.
They like to have the port on the non-side that they have to, so then they don't have to worry about radiating their radiation fields in the port. That's the other issue as well.
Right. So if I read the chart correctly, I think the plan for the Taxol was once a week, and then I guess the Cytoxin was every other, or I guess every 4 weeks or something like that, or I don't know. Is it every other week or every 4 weeks or?
Okay, so it depends on what regimen. So the TC regimen is Taxotere and cyclophosphamide, which is usually we give every 3 weeks, both drugs, so it's just 4 injections. If they're using Taxol, maybe modified regimen, and there is a Taxol, weekly Taxol, but that's usually given in combination or followed or preceded by AC. So I'm not quite sure. The traditional TC regimen that I was speaking about is Taxotere. It's it's best given every 3 weeks. So interesting. So they're giving something weekly though, but still, you could always have a PIC in there.
Yeah.
Right?
No, that's a
it's
good
not
point.
going to be a long treatment. You can just use a PIC, and people have those for 4 or 5 months, and then you pull them out, and then they're not impeding radiation. They're not in that area that you're concerned about.
Right. Well, so this is kind of interesting because what I would say also, if you think about, let's go back in time in this patient and just sort of recalculate what could have happened. So when she presented in December for her breast cancer, there was no pre-op evaluation done in a person that had known heart failure. So that to me is, it was kind of a big place that we could have, impacted what was going on. So that's one thing. And then in terms of the device-based therapy, which I think is still a very viable option in this patient, I would have, what you just said, Susan, about the PICC line and all of that, I think I would have preferred to go that route as opposed to putting a, a port in the left subclavian, which is going to be the preferred location for her device, especially since her disease is on the right. And then, of course, optimal heart failure therapy would be a good idea at any point. But, we haven't, her systolic dysfunction, which has been known since 2008, has not been treated. And, if you just talk about placing a device, you would like to have optimal therapy for at least 6 weeks, preferably 3 months, before you make a decision about device implantation. So I think that those are all places where we really could have improved this story, I think. So I don't know if anybody has any comments about all that.
So I agree. I think this is a very good case to sort of illustrate all the things that maybe could have been optimized if there had been an assessment done at the very beginning, particularly in someone with previous cancer, previous exposure, already have existing heart disease. I mean, there should be red flags going up here when you're looking at how do you optimize their cardiac function, but also try and take care of the cancer. So this would be, to me, is definitely a case where this woman should have been seen up front and discussions had between cardiology and oncology as to, what do we need to do first? How are we going to line up this treatment and optimize both? So very good example.
Yep, I agree with all that, of course, since that was the case that I brought up. So there you go. Now, I really appreciate everybody getting on the call, and we love to hear what people's experience is, because I think that this is a place where we really want to try to raise awareness that there are important decisions that are happening that, if we could provide some perhaps more experienced input at the point where those decisions are being made, then I think it would be obviously beneficial.
Hey, Dan, we have some other attendees we want to recognize. Who's Dr. Parashaw is here from Emory, and we have Alan Kono, and we have Lavanya Kanapali. So I want to recognize all of you for having attended. If you could say hello.
And
Hi
also,
there, this is Sushmita. Very good discussion.
and I see Anju Noria is on also.
Yeah, sorry I joined late, but great discussion.
Great
No
discussion.
problem. So you guys are doing okay up there in the snow belt?
Yeah, we're surviving, waiting for school not to be canceled every day.
It's cold. Dan, I'm freezing.
Yeah, I'm sure it is. It's cold in Tennessee, when it gets down into the 30s, we start shivering.
Yeah, it's down in the 50s here. That
Okay,
50s
guys. Guys.
we're really cold down here in the 50s in Tampa.
Okay, you're wimps because I'm in the real cold where we're in Celsius and it was minus 20 the other day. So you guys don't know what cold is.
I've got a fire in the fireplace in Tampa.
Oh, that's funny.
Oh.
All right. Well, thank you guys so much for joining. And next week, we will do our follow-up on our best practice document. So we'll
The best practice will be at 9:30, correct? And then and then we'll have the meeting. Hopefully, from Gillian Murtaugh, we'll have the meeting starting at 9 on the steering committee for the fellowship. So we'll wait to hear from her, and we'll send a mailing out if she says yes.
Okay, that mail out has not gone out yet, is that right?
That's
For
correct.
the fellowship? Okay.
That's correct.
Hey, Dan,
Okay.
Yes.
everybody stay on for 1 second. A plug that I have a fellowship spot for a 4th or later year fellow in cardio oncology next year that's funded. If anybody at their institution can identify somebody interested, they should call me.
What year would that be? What year is that?
So after anything after a 3rd year.
Can you tell me, is that 2015 or 2014?
So beginning July 1st of this year.
Okay.
2014. We do have a fellow here that we're trying to find funding for. If we can't find funding, we would send her up your way. She's very, very good.
Okay.
So that's an option. Is
What
that
institution is this? I'm sorry.
At Penn, at Penn.
that's Joe Carver, Dr. Carver.
Oh, okay, great. Thanks.
Okay, so if anybody has any ideas or any warm bodies in cold environments, send them my way.
Joe, we could have a warm body in a warm environment if you'd send the money down here.
All right. Well, thank you all so much for joining.
Thank you.
Good
Okay.
job.
Thank you. Goodbye.
Bye.